Good evening, everyone, and welcome to this evening's event, When Science Meets the Bedroom, 50 Shades of Pleasure and Prevention. We're delighted to be working with the City of Melbourne and jointly present tonight's event as part of the AIDS 2014 Cultural Program. So it gives me great pleasure to introduce to this stage our panel for this evening. I'd like to begin with our MC, Sean Strubb, who's the Executive Director of the Zero Project based in Milford, Pennsylvania. Sean, come join us on the stage. Sean is joined at the moment by Dr. Udi Devanovic from the Amsterdam Public Health Service. Dr. Udi. And our third panelist who's here with us to begin is Dazon, all the way from Atlanta, Georgia, and founder and president of Sister Love. We have three more guests who will be joining us. I'll leave the introductions for Sean as they arrive, and they will certainly add to the value of the conversation. I look forward to a robust and interesting conversation as we have this outside the AIDS sector and in the public. So thank you and welcome.
Thank you so much to Brent and to the councillor, but also to the City of Melbourne. Speaking as a visitor, and I think speaking for the vast majority of the visitors and those of us who've been to a number of these conferences, those of you in Melbourne should be very proud because I think we have felt so welcome. And I personally am very pleased because the integration of people with HIV into the planning and execution of this conference has been unlike any conference we've seen in recent years. And that is really remarkable. And I think it relates to why, in relative terms, certainly the state of Victoria has had greater success in controlling the epidemic than lots of other places around the world. And a lot of that has to do with taking seriously the concept of the meaningful participation of people with HIV in the development of policy and the delivery of services. And that's reflected by state support for the networks of people with HIV, meaning the organizations created by, controlled by, and for people with HIV. So seeing that in this conference, and Dazon, I know you've been to a million of these conferences, but it's really remarkable.
You're right.
So what we're going to talk about is a subject that the title sounded great. Actually, getting to talking about it for me was sort of like grabbing smoke. Pleasure and risk. You know, we live in an age when people, before they make a decision to become intimate with another person, they very often do a risk analysis in their head. You know, and how that analysis comes out is influenced by all sorts of things, from the context to you know, stereotypes and preconceptions a person might have, to how horny they are, I'll say, to all sorts of things. Sexual desire operates beyond the rational to a large extent. And the whole role of pleasure in sex, that is what drives people to take risks, and risks they sometimes later regret. Well, we now have, you know, all sorts of, you know, changes and new things in devices and condoms and female condoms and the origami condom and the galactic cap, which I don't think I can explain, and this new membrane material that is being developed, similar to like what we make contact lenses out of, that is much more like human tissue, and is supposedly going to be turned into a new condom. Sid, join us, please. We went ahead and started. We were 6 o'clock, but there was some confusion around 6 or 6:30. So welcome Sid Nova, who is the programs director at the St. James Infirmary in San Francisco, which is a peer-led health clinic for sex workers in San Francisco, actually the only kind of its facility of its type in the United States. So we're very happy to have you here, Sid. And we're just getting started, right. So you haven't missed a thing.
I was early, showed up late.
So, and in addition to the advances and developments in various kinds of devices, there's also all the biomedical advances and the utilization of antiretroviral treatment for prevention purposes. Whether an emergency intervention like post-exposure prophylaxis, meaning when somebody fears they might have been exposed to HIV, a condom broke, or they did something that they regretted. If they start antiretroviral treatment, a 28-day course of treatment, within 3 days of that exposure, it's extremely effective at preventing them from seroconverting and acquiring HIV. So this is an emergency intervention. And then there's also people who have HIV, when they are treated and are treated successfully and get to an undetectable viral load, meaning that you cannot isolate the virus in their blood using the available technologies, we have all sorts of different ways of saying they are virtually non-infectious. The truth is there's not a single documented case in all the scientific literature of sexual transmission of the virus from someone who is known to have an undetectable viral load at the time of the sexual contact. It may be able to happen, but it hasn't happened yet that anybody's been able to document it. And then perhaps the most contentious aspect of this is pre-exposure prophylaxis, which is the concept of giving HIV treatment, antiretroviral treatment, to people who don't have HIV in order to keep them from getting it. So people who are perhaps at particularly high risk of acquiring the virus and will not or cannot use condoms, for example, or cannot get their partners to use condoms, or certainly in the cases of sex workers where it's an economic issue. So pre-exposure prophylaxis is fairly new to the scene and is under a lot of discussion. So with all these new changes and developments, it changes that formula and that risk analysis. And of course, it depends how well informed people are about these different things. And pleasure remains the driving force behind it all. So with that, each of our panelists are going to say just a few words, and then we're going to get into a little bit of a discussion and very quickly involve the audience as you may have questions. So we'll start with Dr. Davidovich.
Thank you. And first of all, welcome everyone to our bedroom. I was asked to actually comment a little bit about the role of science. I'm a behavioral scientist myself. How science have actually been involved in understanding the pleasure aspects of prevention when it came to HIV prevention. And I just want to sum up, I want to be shorter than what I was the other day, that we haven't done, we didn't do a pretty good job in incorporating pleasure into our science. And that we have a great opportunity to change that now. And if I just want to explain why, then when HIV showed up in the actually late 70s, early 80s, we were very busy in understanding the risk behavior, which behavior actually caused the transmission of the virus, and of course, then how can we intercept that transmission? And what we had available at the time was the condom. There weren't a lot of other options, and we were actually, it was more of a survival mentality. We have to get that going as quickly as possible and try and save as many people as we can. And pleasure wasn't really on the at the table in terms of something we really had to consider. This was an effective strategy. It was put out there. Amazingly, it was well adopted, at least among men who have sex with men. That's a nice political term to address, to name gay men, inclusive of all men who have sex with men. And we saw, if we look scientifically on behavior, we saw a wonderful adaptation of the condom throughout the years. We saw that from actually no condom use at the time, because condom use was a contraceptive, not a very popular contraceptive. Research from the 70s showed that only about 20% of the people actually used condoms as a contraceptive. Most people actually preferred a prophylactic solution, which was the pill. But we saw that the gay community adapted the condom strategy. We saw 80% of gay men using the condom during sexual contact with casual partners. And we actually have seen that only slightly diminishing through the years. It's around about 70% condom use, sometimes 60% with casual partners among HIV-negative men. But all of a sudden, we came across more and more strategies that can actually replace condoms. We have the emergence of zero sorting. Zero sorting is actually people both testing for HIV, determining that both of them are negative. Of course, you can be both partners being positive, and that makes it possible to have unprotected sex without a risk of transmission. That was very difficult in the 80s and in the early 90s, because at the time HIV testing had what we call the window phase, the time that you had to wait from a moment of infection until the test was able to detect the infection. That was at the time 6 months. That's a lot to zero sort with casual partners. But now the tests have a much shorter window phase, and I'm looking in the future to the emergence of different types of HIV testing, which are not antibody-based, but viral load tests, which you can do at home. Home tests for HIV, where actually the window phase will be reduced into several days, and then zero sorting testing before you're having sex could be really effective. But this is a little bit music of the future. And at the moment, we have other strategies like pre-exposure prophylaxis, like Sean described, post-exposure prophylaxis. We have having sex with a partner whose viral load is very well suppressed. That means that the viral load is undetectable. All those options has the pros and cons, and actually we're at the first time in a place in science where we should actually not so much concentrate about the strategy itself, but about understanding the choice that people can make when they choose a strategy. So we have to understand, why does someone choose a specific strategy in the context where somebody lives in the specific lifestyle, what kind of implication it will have on his or her life. Can they actually adhere to that strategy? Can they use PrEP properly? Can they use PEP properly? If they can't, maybe condoms are still a better option. We have to understand how people make choices, support them in making their choices, and then also incorporate the element of pleasure, which we didn't all through the years, and see also which strategy provides them in their context the best of pleasure, because that's an important factor. And combining all those elements together, we can actually create a better match, I think, between the strategy of protection and the actual behavior. And if we'll do that, I think we'll have a better chance of people adhering to the strategy. And as I said yesterday, and I'll repeat it again, if science is to meet the bedroom again, it has to take off its shoes and socks so we can feel the grounds better. Yeah.
Thank you. I also want to point out that it's not uncommon when new prevention strategies are introduced that there's a lot of resistance to them, that it takes a while for them to find their appropriate place and to be adopted. I like to remind people that when condoms were first proposed, they were proposed by two men who described themselves as sluts. And they had a great big full-page article in the gay paper in New York that they said, "We know who we are," and described their sexual history, their history of sexually transmitted infections. And this was already after gay men's health crisis and a number of AIDS organizations had been founded. And they felt they were not focusing on helping gay men create safer behaviors. And in fact, a lot of the early safer sex material, including from gay men's health crisis, wasn't about condoms. It was about identifying someone who might have this disease. It was take a shower with him, see if he has red spots. It was about learning how to avoid the danger person rather than promoting behaviors that protected everyone. The second point I wanted to make that really, back then, first of all, when the epidemic started in the U.S., only 7% of the people in the country said they knew a gay person. So the country was meeting gay people for the first time and learning about gay sexual behaviors in bits and pieces for the first time. And no one was interested in talking about the right to pleasure for gay men. And plus, we were dropping like flies. It was wartime. And so gay men forsake their own pleasure for safety and for survival. Well, back then, places compared to today, for those who have access to treatment, of course this is a huge divide in the world of people with HIV, the consequences of HIV infection today are profoundly different than what they were years ago. So the willingness to make that kind of sacrifice, that calculus changes as well. And that's why we need to talk about how we address the epidemic today. So with that, I see it's wonderful to be the moderator. You get to jump in with whatever you want. Faison.
Facilitator's privilege.
All yours.
Thank you, Sean. And Udi, that was great. Thank you.
Okay.
Hello, everybody, and thank you all for coming out this evening, and thanks for inviting me. This is great. And Brent, where did he go?
He had to go to another.
Hats off. Just tell him I'm stealing this. 50 Shades of Grey premieres in the U.S. in February, and I'm sure this is how we're going to talk about it. I'm glad you all took a historical view to this, because that's how I've had to think about my own comments this evening. And the thought that I first had was, wow, I've gone through my own revelation in the last 24 hours since yesterday's session that was the same as this. And I have an organization, Sister Love is a women's HIV, AIDS, and reproductive justice organization. We'll be 25 on Friday. Whoop, whoop. And when we first got started, it was literally to help our local AIDS organization in the mid-'80s. Literally the day that Rock Hudson announced his AIDS diagnosis, for some reason women started calling up and the phones were ringing off the hook. I don't know, maybe we all thought we were Elizabeth Taylor, Grace Kelly, who knows, but they started to get the message, right? 85. And so I started volunteering and learning from what gay men, particularly in San Francisco and New York, were doing around the safer sex parties, around eroticizing safer sex. And I thought, oh, that's kind of different for how we would need to address this issue for women. Sitting in a room talking about sex and AIDS and dying, and then say, here's the condoms, go forth and be safe, and think we were affecting anything. When we were talking to folks, meaning women, who historically, and this is in a Western context, so we're not even yet talking about women in different cultures in the global South, in resource-poor areas where the gender dynamics are even worse and less respectful for women. And we're in a room trying to get folks to talk about sex, and we want women all of a sudden, because of HIV, because of AIDS, all of a sudden we want them to flip the script on being socialized to be assertive in the bedroom, to be able to say what they want, how they want it, what should happen for them, what they aren't going to do versus what they are going to do. When even in the US, over many decades, this has never been the culture for women. Not socialized to be the aggressor or the assertive person in the bedroom. And also not really expected to be the one to express the pleasure, because, we're pretty much objects in the heterosexual context in a lot of ways. The second thing about that was just giving folks permission to talk about it. How do you even get the safe space to have this conversation? And I still want to have sex and have fun. So this is how we came up with making safer sex fun. We created an intervention called Healthy Love, and it's out there now. It's been evaluated 20-something years after it was created. And it's now in the compendium, Centers for Disease Control's compendium of evidence-based interventions that are effective and work for women. What I want to talk about in that intervention was when we first developed it, every element of that intervention really was about teaching folks how to have fun, sex, and be safe. We even had a component, no shit, y'all, we had a component called the Box of Erotic Potential. And it was covered with, erotic pictures from everything we could find. And inside the box was just about anything you could find in your washroom, in your kitchen, in your utility room, feather dusters, fly swatters, chalk, pieces of chalk, bottle of honey, whatever you could find that comes in your house. And one of the exercises was, now you got to talk about what you would do with that item. And it's got to be really sexy and it's got to be really safe. I'm telling you this because when we went through the rigorous evaluation study, years later, the elements that came out of the intervention were all the pieces around pleasure. So we now have an evidence-based intervention, and it just hit me, right? We have an evidence-based intervention that still is effective. It's talking about sex, and we're still teaching women how to put on condoms with their mouths and how to do the best hand job with a condom that they can, just to keep things fun. But at the same time, the pieces that the women love the most in terms of being able to learn more about how to be creative with what their own tools were, is out. And so I've got to rethink what we're doing with that intervention. Because what we now have with the biomedical options is still not enough options, right? And there's not enough talk about how this increases women's access to pleasure and sexual expression while at the same time controlling for themselves that prevention tool. What's different when we were talking about men versus women is my conversation even 30 years ago is really clear. A condom is an absolute choice for a man. For a woman, it will always be a negotiable item because someone else has to use it. Even with the female condom, you're still going to have to negotiate because it's quite visible. You know, that big old ring hanging out, and there used to be noise. So, you know, it had to be negotiated. And so we really are still keen on making sure that we have prevention options for women that we can control, that we don't have to negotiate. Hell, we shouldn't even have to tell anybody that we're engaging in taking care of ourselves and preventing. And we don't have that yet. Even with some of the new options, we still don't have it in that way. So as I come to where we sit now, I think it's really important for us to recognize a couple of things. One is that we also, not only in terms of prevention and the whole array of talking about HIV and AIDS and sexual health, leaving out pleasure, we kind of did that when we talk about human rights, right? And so even when we talk about sexual rights, we're usually talking more about sexual identity, we're usually talking about gender identity, we're talking about sexual orientation, but sexual expression and sexual pleasure are also written into that as a human right. And so if that's the case, then what we are doing needs to make sure that we are also uplifting and protecting those rights for people both at risk who are HIV negative as well as folks who are at risk and living with HIV. And so I think that that's really important. Now, I'll say a couple of things that I said yesterday just because it stirs the pot a little bit, and I just want to bring it back that I'm really clear, is that even in my own world, I am still constantly looking for as many options to protect my vagina and my behind as I have to wash my hair, as I have to brush my teeth. You know, there's thousands of options for those things. I don't transmit anything with my hair. I can't get an infection with, okay, that dandruff thing might have an issue, but I can't, you know, my hair is not a risk to other people or to me. And so if we're not talking about even expanding on the options and now being able to include this conversation around what it means in the bedroom, not in the clinical trial, not inside the clinic or in the exam room when my physician is talking with me, but what it means for me when my partner is talking or listening with me, then that's where this stuff has to work out. And I can guarantee you that if we had sat and talked with all of those folks who participated in all of those trials over the last 30 years, what would be the most important thing that you're looking for in this trial? It's really like, I still want to have my fun. Now, what are you all going to find out from me participating in this trial for me to do that? And that didn't happen. So now we have the opportunity for that to happen, regardless of what type of biomedical prevention we're talking about. And the very, very last thing that I would have to say is that the move that we made in Healthy Love went from pleasure to protection, and we stuck there. And now we have to come back to the protection of pleasure. And if we don't do that, then we will still be sitting here. I know in the US we'll still be sitting there with 50,000 new infections every year, regardless of the options that we have before us. Because when you start talking about younger people who have a lot more information, a lot more access to a lot more sex online and in the movies and everywhere else, they're only going to want more pleasure, not less. And so if we haven't figured it out, then we're just going to be sitting here in 2016 and 2018 and 2020 and forever trying to figure out how to protect our pleasure.
Thank you. I'd like to welcome Garrett Prestage to the stage, and first say that the panelists who have been arriving as we've started, there was some confusion around the time. You should take it as no disrespect to you. Dr. Prestage has been involved in the Australian gay men's response to the epidemic from the beginning. He works at the Kirby Institute and the Australian Research Centre in Sex Health and Society, and has been responsible for many studies of gay men in Australia. Early in the epidemic, Dr. Joseph Sonnabend is a very important person in the epidemic in the U.S. in the earliest days. In 1983, he said, "We will never overcome AIDS until we treat the rectum with the same respect as a sexual organ as we do the vagina or the penis." And what he was talking about was affirming gay men's sexuality and gay men's right to that pleasure. But focusing on affirming that sexuality or that pleasure wasn't really the dominant theme of prevention strategies. And when, I don't know that it was the watershed moment, but when that started to change was really with sort of two developments. One in the 90s, it was something that in the US we used to call the Australian model, which was a laying out how two men could both get tested and go through a process over time to make sure they both were negative or both were positive in order to have sex without condoms. And that was radical. The idea of coming up with a way that gay men could have sex without condoms safely. And then in 2008, the Swiss Federal AIDS Commission issued a statement called, we call it the Swiss Statement, that said that people in serodiscordant couples, meaning one is positive and one is negative, where the one who is positive has an undetectable viral load and has been undetectable for at least 6 months, and the couple's monogamous, and there are no other sexually transmitted infections in the relationship, that they did not need to use condoms. This was radical at the time. It was criticized all over the U.S., sort of hit or miss in terms of how the response to was elsewhere. And there were legitimate reasons to be, cautious of the study, starting with most of the research was on heterosexual couples, not homosexual couples. But what interests me is why they did that. Why the Swiss Federal AIDS Commission went to all this work to come up with this very controversial at the time statement. And it was because in their national AIDS strategy, they prioritized returning people with HIV, returning them to as normal a sex life as possible, and recognizing their right to intimacy and their right to sexual pleasure. And so if, in the earlier years of the epidemic, prevention was fear-based, and we didn't need social media campaigns to scare people because we were dying all around us. Well, as a treatment becomes available in places, the ability to manage prevention by fear lessens. And it becomes that much more important to look at empowering people around their sexuality and around their search for pleasure. Next we have Sid Nova, introduced, and welcome, Sid.
Thank you for having me. I was really excited to be on this panel because it talks about pleasure. At this conference, I've kind of been talking to people and talking about what it would be like if, as part of the conference, there was like a cruising area or like a public sex room. There's like the media center, then there's like get blown room. And I hear people kind of laughing.
It's supposed to be an underwear party.
No place, no problem.
That's not enough, I think. And I think that a lot of the reason that people laugh or feel uncomfortable about this is that sex and drugs is talked about in this very managed way at this conference. We really divorce it from ideas of pleasure, and also from that, in terms of individualization. It's like that we're talking about populations that need to be controlled. You know, ultimately, that's a lot of what we're talking about. And when we're talking about, you know, prevention strategies, we're talking about how to stop people from spreading a virus that is spread through, hopefully, pleasure. I think about this a lot because I'm a sex worker, and people really like to think of sex workers as a population to control. When new prevention strategies come out, we all freak out because there is an idea that institutions will use those as a way to control us. There's, you know, I was talking to a lot of people in the sex worker networking zone about PrEP. There's a lot of concern that PrEP will be something that governments will institute as a requirement for sex workers. We see this a lot. A case that I think about a lot is in the US, there's currently AB 1576, a legislative bill to institute mandatory condoms in porn. A lot of people think this is a really great idea. 500 plus sex workers have signed a petition to say that they do not think this is a good idea. It's because the general population thinks of porn as something very separate from them. They don't know how that happens. In reality, porn is something that is done in all this multitude of ways. So you might do porn with someone who's a lover, with someone who's a friend, with someone who's a total stranger. And the ways that you reduce risk in that scenario would be different in each case. This legislation seeks to make it so that everyone must use condoms, and everyone must be tested every month for STIs and HIV, and if you don't pass that test, then you can't do porn. This ignores the realities of people who are HIV positive who do porn together. This ignores the realities of people who are partners who do porn together. And this also ignores the reality that HIV, there has been 0 cases of HIV transmission in the straight porn industry since 2005. What we're seeing here is a way that NGOs, that politicians have decided that they can manage our bodies and manage our pleasure and decide how we engage in sex. And so what I would really like to talk about here today, I mean, this is a conversation, this is not me preaching to you, is how we engage with prevention technologies while acknowledging that each person has their own way that they reduce risk in their lives, whether they're HIV positive or HIV negative, and respecting that while also seeking to expand the ways that we define prevention. And so that's what I'm interested in talking about.
Great, thank you.
Yes.
Garrett.
Okay.
You're on.
So first off, I should apologise for being late. We were working on being told that it was 6:30 rather than 6, and then when we found out that it was actually 6:30, tried to jump in a cab, and that turned out to be much slower than walking. I'm going to focus on PrEP in what I've got to say, and hopefully it'll become clearer exactly why I focus on PrEP when I'm talking about this. And I'm going to be talking about gay men because that's who I work with. And first off, I want to quote from a recent column, a recent online column that Michael Lasala wrote, and he said, "I've sat in on meetings of HIV researchers and prevention specialists who offered dark interpretations of why gay men are not consistently using condoms, such as low self-esteem, poverty, stigma, substance abuse, and mental illness. What was missing from these discussions of HIV risk are the issues of desire and sexual pleasure." And for me, that sums up our problem. Because according to most of the data that I've seen, especially here in Australia, the men who appear to take the most risk tend to be well-informed, self-accepting, well-supported. And I'm not saying that there aren't some who fit the victim profile, but most don't. And that doesn't make for an easy case for policy and program development. It's much easier when you can say, oh, they just need counselling and the right information, and then they'll behave themselves. But actually, when faced with the opportunity to have a good time, they've probably just decided to go with it instead of living in morbid fear, as they once might have had to do. And many gay men, once they've been properly informed about the effects of treatment on preventing transmission, are keen to have that option available to them, particularly those who are at increased risk. And this, for me, just seems to be arguing around the edges. Treatments work, so do condoms. Neither are 100% effective, but they can be close to it. And I'm not going to get into a discussion about side effects and toxicity and all that sort of stuff. I trust my clinical colleagues, who I know to be well-motivated people, guided by the evidence, and much more conservative than me. I trust them and the science far more than any number of anecdotal claims about it. So those people who want to argue the clinical science should argue it with a clinical researcher, not me. In practice, though, while we seem to expect 100% condom use, at least during casual sex, that's never been the case, even at the peak of the epidemic, and we know that increasingly gay men are being less consistent about it. Someone said online that telling people not to use PrEP is akin to telling someone that they shouldn't take anti-malarials and just don't travel to places where malaria is present. But people have the annoying habit of making their own choices about relative risk versus potential reward. And it isn't always the same as what might be expected within a very narrow public health perspective. One concern is that gay men won't use PrEP consistently, and so it'll be less effective because of that, which could happen. But we don't argue that we should abandon the dependence on condoms as a prevention strategy just because some men, actually a lot, don't use them consistently. We look for ways to complement them with other strategies, and we try to help men to use them effectively. Surely we should treat things like PrEP in the same way. And regardless, in the context of good access to appropriate information and services, gay men at least appear to be pretty good at adherence, and we heard some more about that at the conference. Where that's a problem, it says more about health and education services than it does about gay men's capacity. I suspect that's true of any population group. And then there's the concern that men will be encouraged to discard condoms, but it's hard to see this as anything other than thinly disguised moralism. For some, they think that gay men who don't consistently use condoms are irresponsible, even though there's never been 100% condom use by all gay men. And yet, on the other hand, throughout the epidemic, rates of condom use among gay men have consistently remained at levels that sexual health professionals could only dream of among heterosexual populations. So the idea that gay men as a group are irresponsible is just not supportable. Ignoring these facts, rather than allowing access to PrEP, is simply saying that if gay men don't behave appropriately, then they deserve whatever happens to them. But overlaying this is the fear that gay men will all just turn into rampaging whores. The whole Truvada whore debate that's occurred in the US highlights this. Stigmatising people for using an effective prevention strategy because it might encourage other behaviour that you don't approve of is just moralistic bullshit. After all, condoms make it easier to be a slut and avoid infection too. Besides, there's no actual evidence that gay men are wholesale abandoning condoms in the context of PrEP. It just makes their existing behaviour safer. And it removes the need to constantly worry about the possibility of infection. The either-or dichotomy of the PrEP debate is simply silly fear-mongering. Nobody's arguing to abandon condoms or stop safe sex campaigns in favour of PrEP. But even if some do use PrEP to abandon condoms, what business is it of yours? This is where I think that some social researchers have failed to grasp the potential for using these biomedical tools as an opportunity for advancing sexual liberation. Instead, they focused on the dreadful prospect of biomedicalisation. Our enemy is HIV, and one of the primary tasks in the fight against HIV was always to counter the potential for sex negativity and repression that came with HIV. Here now is a tool that could free us from the fear of sex that's gripped gay men for over 30 years. PrEP could allow us to return to the struggle to free up, to liberate everyone's sexuality once more. This is why I consider PrEP so central at this moment. It offers the potential to free people from anxieties about sex in ways that really haven't been there for 3 decades. We should be discussing the potential for this liberatory moment, that can bring pleasure back to centre stage rather than mere risk avoidance. But instead, at least some people have climbed in bed with the sexual moralists in our own communities to feed conspiracy theories about drug companies and clinicians. It's anti-science and anti-sex and anti-gay. Interestingly, when I said that yesterday, some people interpreted it as me saying that of anyone who argued against PrEP. But what I said, just to reiterate, is that the claims that drug companies and doctors have conspired to replace existing HIV prevention work to get more people on drugs are anti-science, and that using these conspiracy theories to beat gay men about the head for their sexual choices is anti-sex and anti-gay. But, you know, if we want to contest the power of the pharmaceutical companies, then there's a fight that's far more worthy of attention: the issue of cost. Treatments are expensive, or at least they're expensive if we continue to abide by the drug companies' rules. The cost of PrEP is too burdensome for most people, unless, of course, they step outside the strict rules. Step outside the strict rules and import the generic drugs that are available online for their own use at a fraction of the price. I suspect that if we don't find a workable solution to how to implement PrEP everywhere, then eventually we'll see increasing numbers of people doing precisely that. And social research could play a key role in liberating access to treatments from the power of drug companies, instead of obsessing about the use of the treatments themselves. Some, of course, seem to believe that PrEP is only an issue for white gay men in industrialised countries, and therefore it doesn't matter. Well, I've never apologised for being a gay man, and I've never believed that gay men should forego their right to make the best possible choices they can to live their lives in both safety and pleasure. I'm not about to start now. To argue otherwise is simply homophobic. But the peculiar thing is, it's actually possible to support access for all, to oppose drug company monopolisation of pricing policy, and still fight for those who can get access now. This is not an either-or. Gay men are perfectly capable of multitasking and have demonstrated that very ably for 30-plus years of fighting HIV while simultaneously demanding our rights. The problems of inequitable access are something to fight against, not an excuse to beat up on those who happen to have access now. To return to the malaria analogy, should those travelling to malaria-prone areas refuse to take anti-malarials until everyone who lives there has access to appropriate prevention technologies as well? Of course not. Ultimately, this is about choice, just as when women faced being labelled as a slut by going on the pill. Yet in many ways, the pill empowered women because it gave them the power to decide their own level of risk of pregnancy. And indeed, if some women wanted to be a slut, the pill made that more possible as well. PrEP offers some similar advantages in terms of empowering people to take charge of HIV prevention and make their own choices about what works best for them in what circumstances. And of course, if you actually believe the science, that treatments work, then letting people make their choices shouldn't be a threat to anyone, unless you really just don't think that people should be able to make their own kind of fun. Thanks.
Okay, so now we get to the fun part, and I'm going to start by complicating the PrEP discussion a little bit. I'm an advocate for PrEP being available as a choice for people, as I began my comments earlier this evening. But I think there's a very big difference between making something available on individual choice, where we have plenty of science showing that it is effective if taken as prescribed. Getting people to take it as prescribed is another issue, but if taken as prescribed, it's effective. There's a difference between that and implementing it as a public health strategy in a broad way, where we have very little science demonstrating that it will work in that regard, and we have some very serious voices expressing concern about it and even suggesting that in some ways it could possibly make the epidemic worse. The analogy between because some people won't take PrEP properly, that's a reason not to do PrEP, and because some people won't always use condoms, and of course we wouldn't use that as a reason not to promote condoms, is flawed. And and in a way sort of encapsulates three of the concerns about rollout of PrEP in a big way, which gets into allocation of resources and marketing and promotion. What are you educating people about? What are you promoting? How are you presenting the options? Are they all neutral? Well, they're not all equally available or equally accessible. But the three areas, first is cost. You know, condoms are vastly less expensive than PrEP, which is very expensive now. It's going to become less costly as generics kick in and so on, but even still, it'll be much more than condoms. Second, if someone stops taking PrEP, their partner may or may not know that. If someone's not using a condom, generally people know that. Not always, but generally, you know, that's known to both parties. And third, there's been concerns expressed about the development of resistant virus because of people taking PrEP inappropriately. Jay Levy at the University of California, San Francisco has written and spoken about this, and the concern that PrEP could facilitate the development of resistant virus that could ruin one of the most powerful and perfectly good anti-HIV drugs out there. And then there are also the questions of, you know, PrEP in the United States, the FDA approval for it is as in addition to a condom. It is not as a standalone, it's in addition to a condom. But the reality of how the message is being received in the community is instead of a condom. You know, that's its great joy is that you can get rid of the condom and have this heightened sexual pleasure. So there's kind of a disconnect there because there hasn't been the same kind of research on it as when it's as with the FDA indication. We have already seen, not just because of PrEP, but because of the idea of treatment as prevention overall, treating people with HIV to make them non-infectious, that has prompted many public health departments to dramatically cut back on things like condom promotion and other kinds of behavioral-based HIV prevention strategies, just in favor of the biomedical prevention strategy. So, you know, the introduction of a new miracle whatever has other kinds of consequences that we may or may not be thinking through. You know, what about places where if PrEP starts to get used, that then using a condom becomes stigmatizing? So I think particularly for women and for passive partners, trying to get their partner to use a condom, well, if the assumption is people are using PrEP, you know, then it could become that much more difficult to have a condom used. So this is immensely, immensely complicated, and I want to sort of start our discussion by asking Daison a question. I thought when I started to get an understanding of PrEP that one of the really great things about PrEP is that it gave an HIV prevention tool to passive partners, right? They didn't have to worry as much about trying to get their partner to use a condom because they could take PrEP. And I thought women would become great champions and advocates for PrEP, and certainly some have. But a lot of very important voices, including both of the women on the panel yesterday, expressed real concern and caution about that. Can you kind of sort that out a little bit for us?
Absolutely. And I think I made a comment about that yesterday because I thought both Jessica and Tembisa did a great job in laying out the complexities in what that response has and has not been. And I think, first of all, and actually a woman made a comment today, she's just like, I'm just so mad we don't have a microbicide yet. So I think that probably was a piece that I could have said yesterday, which is the advent, the fact that prophylaxis has come along much faster than what we initially, we meaning the women's advocates and allies, for the last 20 years, looking for women's power to prevent HIV in their hands, came from the sexual and reproductive rights community, came from the community of folks who were very much concerned about women's vulnerabilities in terms of violence, in terms of gender inequality and inequity in the bedroom and all of those things, and needing that particular option. So now that we have PrEP, and of course the studies like FemPrep and Voice, the Voice trial that are telling us that, you know, for the women in those trials, that they were extremely dedicated and committed to the trials. 90+% retention in those trials. Everyone participating fully, with including saying, yes, I'm using it, and weren't, to the tune of about 25% actually were using any of the drug at any point.
Wasn't one trial stopped?
And, well, both were stopped. The Voice trial was stopped at different points along the way. And that's what we're learning from Voice. FemPrep we learned a few other things from. But both trials were stopped for futility at somewhere because the infection rates were pretty much equal on both sides. The point, though, is that if we look at the adherence question, right, and I mentioned this before, is we currently have one option in what we consider pre-exposure prophylaxis, right? And that's taking one pill every day, period. And still having some conversation, quite frankly, about recognizing and being able to acknowledge that I'm even at a level of risk, so to speak, that I should even be taking this every day. And that this means I have to think every day about all of that other stuff that everyone else shames me about anyway, which is being a sexual active human being and enjoying that and wanting that all the way I want it, and then I have to take this thing every day that reminds me, and if someone sees me taking it every day, it reminds them, and that may create issues. And so it's still not the perfect option, right? But if we compare, because it's constantly, and thank you for that, comparing the advent of biomedical preventions now to the advent of oral contraception. And oral contraception came along when there was already birth control, right? Just like PrEP, and I said this yesterday too, PrEP comes along when there were already pre-exposure protections like condoms, right? So it's a larger array. But it took years to get a pill that you didn't have to take every day. Now you can take them once a month, you can take them once a quarter, you can take them less than that, you can get a shot, you can get other things, and you still have barrier methods. And therefore you now have a much larger body of women who are using different ways to protect themselves from getting an unintended or unwanted pregnancy, when there were a lot fewer people taking that pill every day 60 years ago. So that's the thing I think that drives this for women in particular, is that thank you for bringing an option, that's still not the one we need. So that's the first thing. The second thing I think that's really important is that the way PrEP is rolling out, quite frankly, it really is, for all the appropriate intents and purposes based on the epidemiology, based on the history of this epidemic, based on the experiences of gay and bisexual men, that the messages really are all about PrEP is for men. And so women are still looking for their place in that. And therefore, they're not going to do a whole lot more advocacy, except for those of us who've been, you know, less problematic allies for the last 30 years. What I think really has to happen is when we know that the microbicides piece is catching up, that there are going to be other topical ways. If there's the gel, if there's the ring, if there's a film, if there's something, and there are different acceptability levels of each and every one of those types of delivery systems. I can tell you this now. I love, check this out. I worked in the feminist health movement 25 years ago, and we had the menstrual cup. Does anybody remember when those menstrual cups, those little rubber caps came out because they would capture your menses? It fits right over the cervix. And no, that didn't take off, just like female condoms. It didn't take off. Why? Because back to the socialization, y'all ain't supposed to touch yourselves down there. You're not supposed to look down there. You're not even supposed to know what is down there. If you haven't seen that new episode of Orange is the New Black, where the entire episode was about whether the urethra and the vagina were the same hole, that's because we're still working on giving ourselves permission to know our own sexual bodies, right? And for me to have something that I've got to put up in there and touch and all of that, that's a whole nother cultural paradigm that has to be overcome. So we still just need more options, and we need it that says this is for women. So that's why we're having some of these challenges and struggles around it. And I would say that the last thing around where women are on this issue particularly is the same way that I absolutely love the ability to just own this Truvada horror moniker. I love that. You know, when women, in terms of dealing with sexual harassment, street harassment, sexual violence, started wearing the slut shirts, and we had the slut shaming parades and all of that, the condemnation from the feminist community rained down so hard. So if you just think about what that would mean to start pushing the whole idea of sexual pleasure and expression and, you know, increasing more power for women to engage in that it's going to be even harder in an era where even the conservative constructs of the feminist community are not behind us. So again, you said it's really complicated. There are really, really many layers, and it's a lot of moving parts, including body parts. And so I think we still have a long way to go. When we hear about the Depivirine ring, and finally there's some other method of delivery, I'm hoping that we'll see another community of women who come out and say, where's mine? Why can't I have it? Why is it that damn expensive? Who's going to pay for it? And all of that. And I'm going to close because I have to apologize and head to another appointment. But love you. I wanted to talk about it, and we have this session tomorrow at the conference. But I convene a group called U.S. Women in Prep, and it's really about advocating on the best science that we need to talk about women and pre-exposure and post-exposure prophylaxis, prevention options, really. But it's also meant as a way to continue educating ourselves and making sure that women stay on the agenda. And we did a informal, not as scientific as I would have liked, study with a survey and focus groups with transgender, sex working, and drug using women. Just in terms of what are you thinking about PrEP and attitudes. This is about 6 or 7 cities that we did this. And all of the standard reasons for why I will or won't engage in PrEP, some of the stuff that you raised in terms of the controlling of our bodies, what my Johns and pimps might, you know, be pushing. Is this going to become mandatory by my pimp for me to have to take PrEP every day? How much it costs, how much people know about it, the stigma that's associated with taking an ARV. All of these things came up really high in terms of folks' concerns and barriers. What really struck, though, was about, of all of the responses, I think the one about the cost, 80% of the folks were really very much concerned about that. But 60% of the folks were actually most concerned, this was their number one concern, was that I want my physician, I want my provider to offer me, if they're going to offer me PrEP, it's because they're caring about my health. They're not giving me and wanting me to take PrEP because they're seeing me as a vector. That's the pushback. That's the resistance. If you're looking at me as, you know, the walking transmitter or the potential transmitter, I'm not going to respond favorably to you. But if you're caring about who I am and what I need and what pleases me and how my health outcomes are important to you, then I'm willing to listen and I'm willing to consider taking this prescription because my doctor cares about me and not about a disease that, you know, for all intents and purposes, certain folks walk in a room and all you see is a virus. You don't see the human being, whether they're infected or not. And I did say that was the last thing, but it wasn't. The last thing is that we talk a lot about this care continuum, right? And so we have this pathway, some people call it the cascade, some people call it whatever. But it's this whole new paradigm of how we know how to track our effectiveness in addressing treatment for people living with HIV. I argue that viral suppression cannot be the panacea, it cannot be the sole endpoint to this care continuum, because there's so many layers of challenges to get from one pillar to the next, right, to get to viral suppression, that we have to address a whole lot of endpoints. But where we live and work, especially in the US, if we have less than a 1% prevalence rate, that means that for me, and I'm a provider, right? So for every 1,000 people that I test, 990 of them are going to come back HIV negative. Where's that care continuum? And it can't only be PrEP. So we have to talk about what pillars exist for people who are HIV negative as well, and what the endpoints are for people who are HIV negative, which is even more like capturing smoke, because that endpoint is being negative forever. And that risk and those vulnerabilities are so fluid. How do we capture that at the given moment and at the given time? So that circles me back around to what are all of our options, and how do we make sure that people know what they are and have access to them and are given it respectfully, because I love the Swiss statement, because we really want to turn back to the fact that, your sexuality, your sex is your humanity. And it's how we get here. It's how some of us stay here. It's some of us stay sane here. But it certainly is. It is a part of who we are, and that makes it a human rights issue, because at the end of the day, it truly is about my dignity. And I'm sorry I don't get because I gotta go. But, Kenyon's here, he can channel me. Nah. And thank you all again for allowing me to be here and inviting me. I appreciate you. Thank you so much. And y'all know, have some fun tonight.
Speaking of pleasure.
No problem.
Sure.
I really appreciate what you said. I thought that you really talked about PrEP in this way that I was happy to hear right next to me. And you also said something that kind of struck me, where you said that people often think of PrEP as a tool for white gay men, and that doesn't mean that it shouldn't be something that exists. And I just kind of want to bring it into the room, kind of the tension that is there, which is this kind of class assimilation. So the population is sluts. Sluts of the population. And then when one part of that population is able to access this tool that enables them to have sex without HIV being a risk, PrEP, it creates a dichotomy. And I think that a lot of the things that we're scared of is that there will emerge these two kind of different classes of sluts. One is those that cannot afford this technology, and therefore are still risk and are still dangerous, and then these good sluts who are able to afford this technology, and therefore their sexuality is no longer dangerous. And that doesn't mean that PrEP isn't something that should be available and used, but I do think that that is the tension in the room, a fear by those of us that are low income, that PrEP will kind of change it so that some people will get to leave the slut name and go on to greener pastures, and will leave us behind.
And that's also, that's of course an issue where healthcare access isn't equal, in the U.S. I think over a 10 or 12 year period, when there was tremendous uptake of the birth control pill from, I think, some point in the mid-'80s to the early '90s, the Guttmacher Institute in the U.S., which is a very respected, policy shop on reproductive rights issues, published research showing that while unwanted pregnancies during that period in white women went down substantially, in women of color they went up. And this is, I think, one of the concerns about, and this goes back to the promotion of it. Nizan said something very interesting. The sort of organic promotion of it from the community is one thing, saying we want this and we're doing this. The imposition of it from public health, and I'm not talking about, nobody's going to, well, maybe, but I hope not. We're not talking about like mandating or requiring, but there are ways that there is coercion and that it can be promoted. We have people in the U.S. who get tested for HIV. They have a very high CD4 count. There is not an ounce of urgency to them going on treatment. There's even a question whether or not at a high CD4 count treatment will overall help them or hurt them. But they are sprinting from that testing center to the pharmacy with a prescription in their hand because they are left with the sense that it is so urgent to get them on treatment. We have people being treated for a public health purpose in order to render them non-infectious, and they don't fully understand that. It's not necessarily for their own personal benefit. So I think there is this kind of from the grassroots coming up. We were talking about this last night. The concept of PrEP is hardly new, because I remember in the 1970s and the early 1980s when we would go to the bathhouses and take tetracycline prophylactically beforehand. And it wasn't because the public health department was telling us to do it, but if we were going to go and engage in that kind of behavior, it was a pretty smart thing to do. The other thing I'll say, then we'll get to your comment and any others in the panel and then to the audience, is to me, one of the frustrations I've had within this sort of AIDS movement of, people have been doing this for a long time, is the so much energy and excitement and push behind PrEP. And we've been struggling to get PEP promoted, and that's been a very long, slow road. PEP is post-exposure prophylaxis. This is an emergency intervention. You only take it for 28 days. And in my view, I'm a little bit like, okay, when, every person who has some reasonable risk of acquiring HIV has a 3-day starter kit of PEP in their knapsack or their backpack. So if a condom breaks or they do something they regret and it's 4 o'clock in the morning on a Saturday, they can't get to their doctor or to a clinic. It gives them something to start on to buy themselves some time until they can get to their doctor, to their clinic, and analyze what risk there was and whether they should continue through the whole 28 days. How come we're not doing that? How come we don't have a 24-hour delivery service, or a sort of a phone triage for risk assessment, and then get that? Why don't we let pharmacies dispense 3 days of PrEP without a prescription? Now we're starting to get emergency rooms in the U.S. are getting a little bit better about it. But, you go to an ER and it's 2 hours, 4 hours, 6 hours. You're not sure, was there that much risk? Was there not that much risk? You're going to have to talk to somebody. You might be, you might have had a few drinks. You might be high. So there is, a Whitman Walker Clinic in Washington has something called the Red Carpet Program, that if you think you have been exposed, you're sort of an expedited process for assessment. That is an emergency intervention. We're not providing that emergency health care, yet so much of the air in the room is being taken up by talking about PrEP. So you were going to say something.
Yeah, I had a few comments on the things that you said. To begin with, from being public health from the Netherlands and representing the public health perspective, we're pretty perplexed on how we are going to roll out, talking specifically about PrEP, how we're going to roll out that out to the public. On the one hand, you have the individual choice that you want to promote and respect. On the other hand, you have costs elements of who's going to pay for it, and of course the costs in terms of also of toxicity and other issues. And at the same time, how you are going to manage a serious scale-up and who's going to be a benefit from PrEP the most. And we have to make informed choices in it. And actually what you see now all around the world is people stopping doing the efficacy trials, which have actually been pretty good by now, and embarking on what we call demonstration trials, which are actually testing real rollout of of PrEP, and we're doing it in Holland, we're doing it here in Australia, also in San Francisco. So we're going from randomized control trials into more demonstration trials to actually see what will happen when we roll out PrEP in the real life. And we have to learn from the data and the empirical data that we collect in order to make an informed public health decision about that. Just as a side note, because we're not going to just think about it in terms of, it's not going to be a thought exercise, it has to be also an exercise that's going to be put there out in real life. And then something else you said is the question whether PrEP is going to stigmatize or marginalize condom use. You know, I also think it might have the completely opposite effect. When we're going to roll out PrEP, we're going to really communicate very well all the implications that the use of PrEP might have. That means the fact that you might have to pay for it, it's going to be expensive. The fact that you might, that it will impact your spontaneous daily life. You'll have to remember to take a pill. And we've learned yesterday that maybe at least 4 times a week in terms of reaching a sufficient efficiency, maybe not the whole week, but it will still, you'll have to remember to take it. You'll have to incorporate that in your daily life when you travel, when you have a sleepover somewhere else, someone's house or something. It will take it will impact your life to a certain degree. It might have some long-term non-beneficial effects on you. Not general, but maybe on the individual level. All those issues have to be communicated when somebody is going to make a choice to use PrEP. And some people would find that very complex and say, hey, what the hell? What do I need that for? I'm just going back to condoms. It's much easier. I see, in a way, almost the return of the condom as a sort of like a peace and quiet strategy, as opposed to the very complex set of rules that you will have to understand if you're going to embark on pre-exposure prophylaxis, as an example.
Can I just clarify one thing for a second? Please don't tell me that you're suggesting that condom use is going to increase because of PrEP.
I'm not saying it's going to increase. I'm saying that people will make the choice of using condoms, and they wouldn't be stigmatized for that because condoms will have very clear benefits. So, I mean, people might even be proud of choosing to use a condom. I'm not saying that numerically it's going to rise, but I don't think people will necessarily become uncomfortable using a condoms. Condoms, in the context of PrEP, will have definite advantages, which maybe not have been had before.
For some.
Yeah, for some, absolutely.
That's right.
We're all talking about an individual scenario per person. And the other thing that I found that's actually very surprising that you were mentioning it, where you're looking at, adherence and probably the emergence of resistance, is exactly the same words of the arguments that we had 10 years back when we were talking about rollout of antiretrovirals in Africa. People say, oh, but we cannot implement the dissemination of antiretrovirals in Africa because, what if people would not adhere for it, and what if, and then as a result, resistance will rise, percentage of resistance, and this was reasons why we actually stalled for I think 2 or 3 years. With the general rollout of antiretrovirals in Africa at the time.
And Eddie, can I just
very same arguments that you were using now. So it weren't those arguments were not correct at the time there, and I don't see a reason why we would do correct now.
Those were my arguments.
Can I just add? And can I just pick up on what Udi's saying, because also what we learnt yesterday was that adherence was A, it was better than what was expected to be, but B, really importantly, was that people who were better informed about what the impact of adherence was, what the potential for protection were, what the potentials for protection were, and were at greater risk themselves and understood what that meant, were much more likely to be adherent. So the take-home message there is you inform people, and of course they're going to be much more adherent. Give them the power of knowledge, and they adhere. And
treatment literacy is a huge issue and deficit across the board in the epidemic. In terms of the resistance issue, I think it's pretty logical to assume that the regularity of compliance with treatment, if you have HIV, where the consequences of that are pretty well known, is going to be less regular compliance when people are basically taking it as an option for prevention, is I think the distinction of that.
All the trials until now didn't show any signs of resistance.
True.
So coming up, by the way.
So let's, Kendall.
Hi, Kenyon.
Yeah, excuse me.
From TAG.
Yes, I know.
So, just quick, this has been really interesting. I'm almost sad that it got kind of a conversation about pleasure turned into a conversation about PrEP, and debating the, I do think what I'll say is this. What I think is interesting, there are a couple of things I think as an HIV negative man, which I don't normally usually talk about because I feel like it's it becomes this thing where you're like, oh, but I'm, whatever, like I'm negative, blah, blah, blah. But like in the context of this conversation, I think it's important because I feel like it actually has brought, men who are negative a kind of a way to be able to feel like there's a way to sort of be in the conversation about something that's impacting the larger community that doesn't feel like it's been particularly present for in a way for a while. So I think that's one piece. The other piece is I'm seeing friends of mine who are organizing sort of community conversations in New York City and Atlanta and some other places, and particularly among Black and Latino gay men in those cities, that what's interesting is that the PrEP conversation has actually helped reintroduce just some basic HIV science and treatment literacy that has been missing, right, for a whole range of reasons. So a number of folks I've talked to who've been doing these kind of community forums have found that it hasn't just been a conversation. The PrEP has also turned into, oh, I didn't know that people aren't still taking, necessarily, handfuls of pills every day, or that some of the side effects that I thought were present, aren't there, right? So I think it has created a space for a kind of re-engagement around some basic HIV literacy stuff that I think is important. And the other piece of it is too, in the context of the United States, is that there's one study that I've seen that's actually looked at that actually, in some ways, providers for, I think specifically around Black gay men, it's actually been the opposite of thinking that you are, even though we are more at risk, in the United States, that there's not been the same kind of assuming that because you're a Black gay man in my clinic, you're at risk, so I'm going to sort of demand that you take PrEP. It's actually been the opposite. They think we're irresponsible and can't handle the adherence, so they actually don't prescribe it more than they do to white gay men, right? So we actually have the kind of complications around race, I feel like, are whether or not you get sort of overprescribed something or not prescribed something at all because of the assumptions around your capacity to adhere, I think need to be thought about in so much as we also are kind of trying to sort of protect people from what we feel like are, a whole range of complicated feelings about PrEP that we have. And then I hope we stop talking and talk more about pleasure.
But I think it's actually the PrEP conversation that has sort of opened up the opportunity to talk about pleasure, because that's what's driving a lot of people's sort of desire for PrEP, is sort of pleasure is important, and this can bring it back. But we had the same problem yesterday trying to keep on pleasure, and it got sidetracked by PrEP.
Someone tell a dirty story.
Anybody else have a question or comment?
Look, I'm stuck on PrEP again. Not so much the pleasure. Look, it's just around the prescribing of PrEP. Is it like PEP in that after exposure, if you wanted to stop taking the PrEP, that you'd have to go for 28 days and then you could safely stop taking PrEP? Is that how it all works? I'm just a bit curious. So you understand what I'm saying, or do you just have to, is there a period when you can stop taking it safely after having, I guess, unprotected sex?
There's not clear science on that, and like so many things in the epidemic, we've kind of had to guess and figure out and sort of find a path through that sometimes is right and sometimes isn't. There are a lot of people that think post-exposure prophylaxis, that of whatever efficacy it has at the full 28 days, that it might be 70 or 80 or 90% of that even after just 10 days. But you can never do that trial because it'd be an unethical trial. So,
can I just add about
sure.
that there's actually been no clinical trial evidence for PEP use. So that's a complication in and of itself. And we actually heard, and you're right, that there's a lot of confusion around this because A, it's difficult to do the trials, and B, it's just not clear at this point. But we did hear yesterday, for example, that, and at this stage I'm pretty sceptical of this, but nonetheless it was that taking PrEP 2 days before, for two consecutive days before and 2 consecutive days after, is adequate. Now, to me that sounds extreme, but that sort of shows the extent to which there's confusion around this point, which would potentially say 2 days after, whereas the way that PEP is administered is 28 days after. So there's an extreme variety there. I think that probably the consensus, and you're right, the consensus has been that somewhere around 7 to 10 days is probably sufficient, but you'd probably still end up going with the 28 days because that's the sort of official line.
And yeah, if I just may add about the trial that Garrett was referring to, it's called the on-demand PrEP, and that's a French trial, and actually we were very eager to listen to their efficacy results, which I think are going to be next year. And the idea is that you have to plan in advance your moment of pleasure, and remember to take what's crucial about making the post-exposure shorter is that you have that you at least remember at least 2 days in advance, or at least you'll have a dosage before the exposure. So, and of course with post-exposure prophylaxis, by definition, you don't have that dosage in advance, and then on the safe side you stay 28 days, which of course could be probably shorter. But so it's all in the making now. I mean, it unfolds now as the trials provide results, and I think we'll see that a lot will change in 4 or 5 years in terms of how we use the antiretrovirals to control possible exposure and infection, and we probably will be able to use it in our advance in terms of allowing more pleasure into our sex life. We just have to be a little bit patient if we want to do things based on empirical or let's say scientific evidence.
Can I just add the other point about that? In the Australian context, of course, right now you can't be prescribed PrEP because it's not actually.
And as I say, so most of the discussion around PrEP that you hear about is an assumption that people are going to take it all the time for, whatever the course of their, sexual life. And, a lot of people don't have that spontaneous sex. They don't have sex as often, or they can plan, or they're going on vacation and they know they're going to go on a sex binge or whatever it is. And, that's all kind of the beginning stages of being fleshed out, if you'll forgive the pun.
Well, the scenario that I was talking to somebody today about was that some people that live some distance from a metropolitan area, but they might visit the city every weekend. And so these possibilities around short-term prior and after might actually be really helpful for them.
Yeah. And we think about it very black and white now, in the sense of, I'll have to take it every day, or I'll have to manage it just before I have to predict when I'm going to have unprotected sex. And in the future, I see it more as sort of like having another option that you can put out there. So maybe you'll be very perfectly all right with using condoms most of the time, but then you know that you're going on a gay cruise on the Atlantic in the US, and you decide, during that cruise, I'm going to make sure that I'm going to have lots of tons of sex. I'm just going to make sure that I'm going to take that for a week. Why not? Let's say someone is in a depression state. He's depressed. He broke up with his partner, and is really not in a good state. And he knows himself. He knows that when he's not in a good state, he doesn't take as good care of himself as usually. Why wouldn't we offer that person a way to bridge those 2-3 months? and then stop, and then go back to condoms. So, I mean, there is going to be so much, huh?
If he wants.
If he wants to, of course. No. But what I'm saying is there's going to be so much flexibility in this story. It's not going to be so black and white in the future. And I think we have, in the first time, a great opportunity that after years of social science, when we actually dichotomized sex with condom is good, and condomless sex is bad, while condomless sex before the rise of HIV was just normal sex. Anybody had a right to do that. And how we took that normal sex and made something very diabolic out of it. For the first time, we have a chance to unveil that, or to, how do you say that? To reverse that and return to just sex.
And that's where
and sex, and sometimes you'll do it with the condoms because it suits you right. Sometimes you'll deploy other methods. This is where we're heading, and thinking of what will work best for you and bring you the best of pleasure. I think that will take the lead in the future, I hope.
And that's where I think that social research has a real potential for breaking down that dichotomy.
Let's hear your choice.
Two quick things. One is that I'm glad to hear people saying, why are we steering away from pleasure? Because I want us to stick to that for this discussion. But I also don't think that we've gotten that far away from it, because I think PrEP and pleasure are very closely tied together. So I don't want us to sound like we're saying, I'm going back to PrEP now when I talk, and I go back to pleasure now when I talk. They're not separate. These things that actually are very closely intertwined for a lot of reasons. And the second thing I'd like to say is, I don't have a dirty story, but I will say this. When you mentioned earlier about having rooms that might be about fun and pleasure and sex at conferences like this, some of the people in this room didn't laugh because they were uncomfortable. They thought it was a good idea.
Good.
Other questions?
I come from Africa, and we being someone who comes from a culture where it's so difficult to negotiate sex and pleasure with your man, and it's still happening. And here in Australia, I work with communities as well where a man leads. There is no discussion, no. Of course, we empower women to say you should negotiate. If you feel you don't want to, you should, but it's still happening. We can't ignore that. Regarding these all preventions that you are talking about, what has been done to actually help these communities or women, and especially women who don't have the power to negotiate about their pleasure and sex?
I think that's a really good question. In San Francisco, we had this thing happen where there used to be these different ways that we did prevention. One of them was education, one of them was community building, and the others were test and treat. And they decided to move the prevention to test and treat only. And I think in that we lose a really amazing way that we do risk reduction, harm reduction, which is like teaching people how to talk about the yes of sex, like how to get people to consent to sex and like seek the things that they want. That's a really hard prevention tool. It's really complicated. You can't just give people a pill. You can't just give people a condom. You have to get them to feel comfortable to like build the kind of sex that they want. And I agree with you. Like what is being done in our community to make that, what should be really the #1 prevention tool.
And that's the concern about PrEP gutting these prevention budgets for, broader, more empowerment kinds of things that deal with all sorts of situations in people's lives, rather than just this one specific thing around. The other thing that a financial issue in the U.S. has gotten very little attention is that PrEP shifts the cost of prevention out of the public health budget and onto the budget of the payers for the drugs, insurance companies or the Medicare or Medicaid, wherever it is that the PrEP is getting paid for. That is one of those kind of invisible incentives, systemic incentives, in governance that is difficult to measure, but that a lot of people think is a factor at play here as well. So, we have one last question from someone. Would any of our panelists like to make a closing?
I just have to say, I think it's a little meta that we're all talking about like whether PrEP will or will not dominate the conversation. It obviously is. And I also would like to, I think that, I'm sorry I didn't get your name. Radhika, nice to meet you. I would like to see when we talk about programming for the next International AIDS Conference to talk about not just biomedical interventions, but talking about how we have conversations about sex, how we have conversations about pleasure, and making that a prevention tool again, instead of just medicine.
Gary?
The only thing that I just put back onto the table is that that while issues around cost are really key, they're also not necessarily a barrier, because, as I said, we don't necessarily have to abide by the rules that the drug companies have set. And to reiterate that I think that we're at a moment where the biomedical technologies are actually offering us the opportunity to take advantage, to actually put pleasure back front and centre in the way that we talk about, we'll talk about sex, yes, but talk about prevention as well.
Yeah, we have now more choice than ever, and we have to all be able to make an informed choice that will fit us, that fit our lives the best and give us the best of pleasure. And I think we shouldn't be missing on that.
Okay, well
individual choice.
And as important as individual choice is, it's certainly important to me, I think this is a much more complex and nuanced conversation than the way it is played out in the U.S. to date. And so as other countries and communities approach it, I hope that you'll be able to find that more nuanced conversation instead of looking down the road at some of these unintended consequences that that may or may not come to pass depending on how we bring PEP into the array of prevention strategies. And thank you all very much. Thank you to Melbourne Town Hall, and have a good evening.